All right, good morning, everyone, and welcome once again to another installation of the NB Heart Center CV weekly rounds. This morning, I'm really excited to have one of our cardiology colleagues from the Moncton City Hospital, Dr. Sherief Kamel, present to us. It is a testament, I think, to the working relationship that we have with our referring docs, and I think, you know, what really works as a collegial relationship. I mean, it's great to be able to pick up your phone and text each other and kind of be on top of patient care regardless of where they are in the province. And Sherief is really a testament to that good ongoing relationship, whether it be through our collaborative efforts at the NB symposium get-togethers, and whether it just be as far as managing patients are concerned. I really wanted to Sherief to talk about infective endocarditis at a non-surgical center. I think as surgeons especially, but even as cardiologists here at the Heart Center, we tend to have a little bit of a skewed view because we get people sent to us that reflect those who are really in need of some sort of invasive management. But having said that, I think there's a much larger denominator of infective endocarditis, whether it be here at the St. John Regional Hospital or across the province, that are managed completely differently or without any sort of invasive approaches. So I thought it would be great to get Sherief to speak to this. And without further ado, I'll pass it over to you. And once again, if you have any questions, please feel free to populate the chat box, or at the end of the talk, unmute yourself and ask away. Sherief?
All right, thank you very much, Ansar. Thanks for asking me to do this. It's an interesting topic because even myself working as a community cardiologist here, I don't think I even see the vast majority of these patients. I think the vast majority of these people are managed under infectious disease, and then we're asked to kind of be consulted when things are potentially a little bit more complicated, or if they need further investigations like a TEE, looking for the diagnosis. But I have conferred with a couple of our infectious disease colleagues, and they gave me some excellent information of what the typical patients are that they're seeing currently. Here's my disclosure slide. I don't think that there's anything relevant for this talk, but to be appropriate, I will. So I'll start with the case. So this case is a 36-year-old gentleman, basically had a 4-month history of feeling unwell, lost about 20 pounds, was having chills, night sweats, even had anemia on his labs, and he was being sent for colonoscopy with regards to that. He'd actually been able to play softball all summer, although just did not feel the same as he usually did. He actually came to the emergency department because he had pleuritic chest pain. And when he came in, he had classic findings of this, and he was started on NSAIDs and colchicine and was feeling a lot better. But an echo had been ordered. So this is his echo. And for those of you who don't know what we're looking at, here's the left ventricle, here's the aorta, and here is the mitral valve. And all that kind of blue, kind of greenish yellow that's kind of coming back, that's here on this side, that is aortic insufficiency. So basically this gentleman had severe aortic insufficiency that we just happened to see completely out of the blue. And you can kind of see, again, this color that's just coming all the way back, that's all aortic insufficiency. And so we had the question, is this person sick because of, could this be endocarditis? Could there be some other kind of ongoing valve problem? Maybe he had a known valve problem for years and we just didn't know about it, we just happened to catch it. But he gave enough constellation symptoms, so we actually sent off blood cultures, and it grew a very unusual organism, group F strep. He was placed on antibiotics, and then his ECG started to have some changes, PR interval actually widening a bit, but actually coming down. And he went on to have a TEE. And this is his TEE. And I just want to point this little pocket right here where the pointer is. That is actually a sign of an abscess that can happen at the aortic root. And I don't know if you can see it as well on this one, but just down at the bottom here. Then when we actually put the color on, you can see all the blood that's coming backwards into the left ventricle, but there's also some blood that's actually coming across into the right ventricle. And you can also see it from this particular view, same thing, which is going down into the right ventricle. So we suspected that he had a VSD there as well. Now, he does give a history that he was told that he had a hole in his heart since the age of 10, so it might have been, so we suspect it was pre-existing. He did have, there wasn't any actual vegetation on the valve, but he did have something that resembled an abscess. And given the whole story, he was transferred down to the heart center, and where he ended up having a bioprosthetic aortic valve replacement, repair of the aortic annular abscess and perimembranous VSD. So this is just an example of, a case that, we were asked to get involved in because things, were not clear. Actually, it was for another diagnosis, and we actually made the diagnosis. But this was one that did require transfer. So what are the typical presentation? I mean, most people come in with kind of fever and chills and weight loss, and then just a variety of constitutional symptoms as outlined there. I won't bother you with rereading them. They do sometimes come in with the complications related to endocarditis as their presenting symptoms. So some of the cardiac complications include valvular insufficiency, heart failure, even heart block. In this gentleman, he did have valvular insufficiency, but he didn't have heart failure. So it just kind of led to the idea that there might have been some chronicity for this particular illness. Neurologically, people can present with strokes, they can present with bleeds in the brain, abscesses. Some people have septic emboli to other organs, such as the kidney, spleen. If they have right-sided endocarditis, which we'll get into a bit more, they may have pulmonary emboli, which look like cavitating lesions on a CT. They can have infections elsewhere in the body, including like the vertebral bodies, discitis. And some people will even get a systemic immune reaction. So depending on the type of organism, they could get a glomerulonephritis, and you may see abnormalities with your kidney. These are the classic findings of endocarditis, and by classic, they're actually quite rare. I have to say I've seen probably an occasional a Janeway lesion, and that's maybe an occasional splinter hemorrhage, but these seem to be more seen in people who have kind of a chronic endocarditis or more subacute. It's not acute. A lot of our endocarditis is now being caused by Staph aureus, and Staph aureus is a very virulent organism. So we tend to get them fairly acute, and they don't tend to have these lesions for it. So it's kind of more of the classic older group strep viridans type of endocarditis that you could potentially find these, but we don't really see this anymore, but this is what's in the textbooks. So how do we make the diagnosis? Duke's criteria is actually something that is still used, probably, like I said, probably more so by the infectious disease specialists. I think for most of us who are involved from a cardiac perspective, I mean, you have to have a bug that basically suggests that you could have endocarditis, that it's one of the typical bugs. And then you have to have something that actually shows on an echo that there is evidence of vegetation that you would be suspicious of, that would be in keeping with that. There are some clinical criteria which are listed here in terms of minor, and basically a combination of these major criteria and the minor criteria help to make your diagnosis. And so basically there's basically you have either a pathological criteria or a clinical criteria. If you have any of these combination of things, so 2 major clinical, 1 major, 3 minor, or 5 minor, then you have evidence of endocarditis definitive. If you have 1 major, 1 minor, or 3 minor, you get it possible, and rejected would mean that you had another diagnosis or they got better really quickly and it didn't fit. To give an example of one where, you're pretty sure they had endocarditis, but you don't actually have any of the criteria to really to actually fit in definitive. For example, a patient who was an IV drug user who had presented with typical symptoms, had a bug that was in keeping with endocarditis, and had cavitating lesions on their lungs. But when you actually image their heart, both with TEE and with in transthoracic, you had no evidence of vegetation in that case. In that case, you're pretty sure that it was, given that they had all the risk factors, they had the bug, they had the complications related to it. You just never actually found it. So that person would have been treated as infectious endocarditis. This is a nice little algorithm that I found in terms of when to do echo, and it's probably helpful for people who, are helped to investigate this. But basically, if there's a significant suspicion of endocarditis, if you do the TTE and you have it, then, well, I think you're essentially done. If you don't, and then basically you decide how you're going to manage them, whether or not they're kind of considered a higher risk person, where there might be risk of complications. Maybe a TEE would be helpful in that way. Or on the alternative, if there is no high risk feature, you see a small vegetation, they're on the appropriate antibiotics, they're improving, then you may not necessarily need to go any further than that. Now, in all honesty, probably most of these end up being negative, and you're actually over here, and then you have to decide at that point if your suspicion is high or they're high risk, then you would consider a TEE. And then obviously, if you have a positive finding, then you have your diagnosis. you have a negative finding, then, you know, if you don't have another diagnosis and it's still suspicious, maybe even repeating the test afterwards in about another week might be reasonable to just make sure that you're not missing anything. I talked a little bit about the microbiology. The microbiology has changed quite a bit over the last couple decades. We're probably, the vast majority of infective endocarditis is probably related to Staph aureus. Viridans strep is still number 2. This used to be number 1 for many years, and then enterococci. And then you basically get some of the coag-negative staph and then a variety of different organisms. Strep bovis, just a reminder that if you ever see strep bovis, this is often from the GI tract. So people are often encouraged to have GI investigations to make sure they're not missing a colonic malignancy that could potentially cause that to happen. And then the other one is that we have certain types of gram-negative bacilli, which are the Hasek organisms, which encompass 2% of them, which they're usually pathognomonic for endocarditis if they do have it. But again, those are probably more on the rare side. In terms of prosthetic valves, that varies depending on what stage you are. So having a prosthetic valve and a positive blood culture puts you in a different category where you would be a lot more concerned that they may have the emboli, or may have involvement of that valve. Depending on where you are, usually the ones that are more than 12 months, strep is probably the most common organism that you would see, or staph. Those would be the 2 most common. So I'm going to just go on to case 2. So this one doesn't actually have any imaging, but this is an example of one that might have stayed in our institution, that would have stayed in our institution. So 72-year-old male, he had an AVR and a Bentall procedure in 2014 and basically presented with constitutional symptoms, fevers, chills, weight loss, and then was found to have positive blood cultures for Enterococcus faecalis. He was started on treatment for that. He actually underwent an echocardiogram, didn't have any obvious vegetation, and then had a TEE, and there was nothing that was obvious seen. And because of the fact that he had a Bentall procedure and a highly concerning organism for potentially causing endocarditis, he did have a WBC SPECT CT, which showed no increased white count at the level of the aortic root. So regardless, and this is one of those cases where, yes, we never actually met the diagnosis, but you have a high-risk person in terms of having had a previous cardiac surgery with prosthetic material, as well as an organism that is well known to cause endocarditis, that they treated him as presumed endocarditis for 6 weeks. And he improved quickly, like his cultures became negative very quickly. Again, features that were not suggestive that they needed to necessarily go down for any kind of intervention. I'm going to talk a little bit about right-sided endocarditis because I think this kind of falls into kind of the changing demographics that we are seeing. So right-sided endocarditis usually involves a tricuspid valve. I guess occasionally you could see the pulmonic valve, but I'd say the vast majority are tricuspid. And we're seeing an increased number of these, especially in the people who use IV drugs. Staph aureus is the vast majority of these cases because it is a common skin organism, but you can get different ones such as strep and enterococci. Because people use and prepare drug equipment in different ways, they will often use saliva either to dissolve their drug or to actually prepare their needles. And so we can sometimes see some more rare organisms that can cause endocarditis in these people. And usually it's because these are colonizers of the oropharyngeal flora. The other thing, one thing that I learned recently was that even using the same materials that as opposed to just the needles, so the preparation stuff, especially for hydromorph cotton, can lead to increased risk of Staph aureus. In fact, one way that has been used in other parts of the country, I believe it was in Ontario, was to actually supply them with equipment so that they can actually mix their stuff separately from other people's and not share. And they found a significant decrease in the Staph aureus bacteremia that was happening. So we often refer to these people as people who inject drugs, PWID, you'll see them. And really, you know, the focus on these people is one, yes, you have to manage their endocarditis and treat them appropriately. But in order to help try to manage them, there seems to be kind of 3 main pillars. All these people have troubles with money, food, and shelter. And so a lot of the issues that come with this is a lot of social work involvement for them. Because a lot of these people have been using IV drugs for so long, they're at risk of hepatitis C, and a lot of them are on narcotics. So finding opiate substitution, such as methadone, and oftentimes one of the physicians who's involved with our methadone clinic gets contacted to help with people, especially while they're in hospital, and hopefully to help them as they transition out of the hospital. This is just a sign as to how much we are seeing across the world. So this is not just a phenomenon in Western Canada, Western Hemisphere. It is actually all over the world. Most of the people are actually located in China, but then again, the denominator there is 7 billion. So, is over 1 billion. So we have to take that with a grain of salt. But you can see the proportion of people, that we have, and so it is a worldwide phenomenon. Other complications that come with this are, things that, usually related to either the injection or to recurrent, embolization. So people can develop meningitis, they can get soft tissue infections where they're injecting, they can develop pneumonia and cavitating lesions in their lung as a result of embolization. They have different risks for hepatitis B, C, HIV, so other illnesses that are bloodborne, as well as you can get osteomyelitis or septic arthritis. So basically, it is a systemic illness, and you have to be aware that these complications can happen anywhere. As I said, the mental and social health complications are quite high, and you can just see all the different aspects that are involved, with this particular population. Including a large amount that are involved with incarceration. This is some data that was provided to me by Dr. Gord Dow. He's one of our infectious disease colleagues, and he presented this at his grand rounds last year with regards to endocarditis, and was just showing the numbers across horizon. The blue one here would be Moncton Hospital. This would be St. John. Fredericton, which I was quite surprised, Fredericton has quite a fair amount, and then all of Horizon as a whole. As you can see, St. John seems to get the most, but I think that also includes the fact that some of the patients from Moncton and Fredericton and elsewhere get referred there for their cardiac surgery. So yes, there's probably more there, but I think some of it is a bit of a referral bias, when it comes to it. You can just kind of see the overall number seems to be going up. This is only the first 6 months, and I got to say the last while, especially this year, they've seen a lot more, probably a combination of people getting CERB and not having as much to do, thanks to the pandemic, that is probably contributing to this. And then endocarditis admissions, this is just on an annual basis. You can see that the numbers are gradually increasing over the past 5 years. And so here's case 3, just to round it out. It's an unfortunate case of a gentleman recently. I still don't know the full details of what happened afterwards, but basically 29-year-old guy, IV drug user, is on methadone, was found to have hepatitis C, untreated, came in a hospital with typical constitutional symptoms, had positive blood cultures, ended up having an echocardiogram. And this, so just a reminder, this is your left ventricle, this is your aortic valve, your aorta, the left atrium, and here is your mitral valve. And you can see here that there's a vegetation on this on the atrial side of the posterior mitral valve leaflet. And oops. And you can see it from this view a little bit easier, this ball that's right there. So he was started appropriately on antibiotics from the get-go. About 2 days later, that was when we were kind of consulted to kind of say, hey, should we look at this a little bit more? He's not looking well. So I think if he had rapidly improved, this would have been a guy that maybe if he'd improved and cleared his cultures rather quickly, he may not necessarily have needed any intervention. But unfortunately, he got sicker the next day. This is just looking at mitral regurgitation, and it's just basically this color that's coming back is basically the regurgitation. It's coming in at a weird angle, partly related to where it is in the valve. And again, you can see that regurgitation coming back this way. Hard to quantify. It's just based on these images. So we were consulted. He started having more shortness of breath, orthopnea, and his fever continued despite being on antipyretics and antibiotics. And he had a chest x-ray, which suddenly showed that his cardiac silhouette had enlarged significantly. He had a new marked first-degree AV block up to 320 milliseconds. And then as he was being transferred down to, because of this change, he was being transferred down to CCU for further monitoring, and he had Mobitz 1 heart block. So he's having progression conduction system disease. And this was, so we repeated the echo with the TEE. And so you can see compared to the other one, he's got a significant pericardial effusion that's developed. The valve lesion is still there. We're actually able to get a little bit better pictures because he was a bit more cooperative at this point, probably more sedated than anything. So just to give an example as to what has changed in a matter of less than 48 hours. And then we went on to have a TEE. This is looking at the aortic valve, and this would be the left atrium, the right atrium. And in this area, you can see a little bit of a change in this density here. And that was suspicious of a potential abscess that was running between the left atrium and the left atrial appendage, and the aortic annulus. Here's a look at the valvular lesion. So it's a fairly good size at this point. I think still it measured like 1.8 centimeters at the max. And here's the signs of his regurgitation. You can see that color coming all the way around in a kind of a hugging jet. So there was significant regurgitation. And then there's just another look at the same thing. So you had to kind of move around to actually get the right leaflet, which we estimated was around A3, P3. Now, during our look, this is a little unusual, so I thought I'd point it out. I've never seen anything like this. There's this kind of mobile thing that shows up right here in the right atrium. We had a tough time trying to figure out exactly where it was on the esophageal echo, and we actually went back to the transthoracic, and you can see it here, which is actually the opening of the coronary sinus in this area. So because of how sick he was, the progressive heart block, and so forth, we referred him down to the heart center. He did undergo surgery a few days later. He did have a mitral valve replacement, an abscess was noted, and he did have a mobile structure at the opening of the coronary sinus, which was positive gram stain. So I do believe that this was an extension of his endocarditis. There are case reports. I looked it up afterwards that there are case reports of vegetations that are kind of stuck at the opening of the coronary sinus. Unfortunately, I don't know the details, but I understand it was a complicated course, and he unfortunately died in hospital 3 weeks later. With regards to this, so a rather unfortunate case, but I think rather a sign of how sick these patients are, and these are potentially people who will die at a young age, and with regard, going forward. So addressing some of these social issues, and all these people whenever there's an opportunity, I think is a point. So involvement of cardiac surgery, so obviously there are points where we do need cardiac surgery, and there are indications for that. And so basically any form of prosthetic valve endocarditis, at least a discussion, depending on the person, may try medical therapy first, if there's any kind of cardiac device. Heart failure that's basically refractory to medical therapy that you cannot stabilize. I mean, in reality, the best thing is to have them, if you can sterilize them and, over several weeks, and can actually maintain them stable and do surgery later for people who have significant valve problems, that is probably your best course of action, because then you're less likely to have infection. But there are points where they're unstable and you just cannot manage them, and then you have no choice. Fungal infections are consideration, for surgery, and basically people who are having recurrent embolism, whether or not it's strokes or embolism elsewhere, would do it. So those are indications for transfer to surgical sites, or consideration of transfer to surgical sites. So having a discussion at that point. In terms of actual surgery, this is where the heart failure, so in terms of refractory to medical therapy, you cannot control the infection, suspect an abscess, or certain organisms that can be done. And then depending on the case, vegetations based on their size may be considered for surgery. For right-sided, basically they would have to be resistant and basically to any kind of treatment, or potentially valve vegetations greater than 20 millimeters with recurrent pulmonary embolism. This is a little bit more of a complicated course because often these people are IV drug users, and so surgeries on these people then come with complications down the road, especially if you have to use any prosthetics, you know, because they're going to be at higher risk of seeding. And then you get into the ethical discussions and what is the most appropriate course of action. So it becomes a very challenging population. And, you know, and these people are discussed at length, usually at the cardiovascular rounds, between surgical team and the cardiologists in terms of what is the best course of action. So in summary, endocarditis is a disease that, depending on the case-by-case basis, involves collaboration between multiple disciplines, including infectious disease, cardiology, and cardiac surgery. And unfortunately, we are seeing increasing number of endocarditis, which is being, you know, pushed by the increased number of IV drug users, you know, in our communities. And this is not a problem that appears to be going away anytime soon. Thank you.
Sherief, thanks so much. That's fantastic. Perfect. All right. I'm just going to get you to stop sharing your screen there, and then we can get your perfect. And I'll just open it up to questions. This first question, I guess, from JF, and especially when as it relates to the IV drug population, just, you know, safe injection sites, you know, whether or not these are readily available in New Brunswick. I get the impression that they aren't, and how as CV specialists we can be better advocates for this, because clearly part of this is just the prevention of infective endocarditis in these patients starting at a much earlier phase. I mean, it's becoming a growing epidemic in our population.
Yeah, I mean, I know that locally we have a clinic, I think it's called the Salvis Clinic, and they're heavily involved with kind of this, you know, more of a homeless population and so forth. I don't know if they specifically have, you know, needle exchange and so forth there, but certainly something that you're right that, I mean, the social aspects of this is probably the biggest thing, and prevention is, you know, probably our main area that we should be focusing on.
Yeah. The other question, I guess, is from your standpoint, and obviously, like, you know, it's kind of like the levels of kind of management of endocarditis, whether it be at the level of the family doctor internist, then, you know, to the local cardiologist, and then eventually to the heart center. From your standpoint, you know, is your opinion that, you know, every endocarditis that comes through the Moncton City Hospital should be referred to in some way, shape, or form? Or are you of the mindset that, you know, how we're managing these people is okay? And the reason I bring that up is that oftentimes by the time you're either notified and or we are notified, you feel like things have just progressed along a little bit further than you would like. And you're left with this, like, but then having said that, you know, it's not necessarily what we want, which is seeing every single person with, you know, a positive culture and a plus minus echo finding.
Yeah, I think that the way it's being done, I think, is working well. I think our infectious disease colleagues know when to contact us when they need imaging. They're well aware of, you know, the complications and when to kind of progress. They will often pick up the phone and call you guys directly, especially if they say, you know what, this is a situation that I have. You know, at least to involve you in some of the complicated cases, maybe a prosthetic valve where maybe there was positive blood cultures and maybe a small vegetation in terms of what the appropriate management is. So I feel like there is communication that way. I don't know if, you know, as a cardiology group, if they have a small vegetation on tricuspid valve, if we're going to add a whole lot in those particular cases. I think we had probably more when there's left-sided endocarditis. And we're looking for extension, and then we're looking for complications related to heart failure and so forth. But I mean, once that valve goes, if it completely ruptures, then, you know, that's unfortunately when we're getting to the point of, okay, we need to do something. You know, can you predict which ones will actually do that? I'm not really sure. So, yeah.
That's fantastic. Great presentation. I think where we've hit the 8:30 mark, we'll stop here. But I love the data that you showed as far as the increasing number of cases are concerned, whether it be across horizon within the Moncton City Hospital. I think we are seeing the same thing here. And I think from a surgical perspective, we would definitely attest to the fact that the types of cases that we're seeing are increasingly complicated. These aren't just straightforward replace their aortic valves. I mean, this is, you know, fairly advanced reconstructions that are high risk. And as you presented in that last case, I mean, they don't always have good outcomes, unfortunately. So clearly a problem that we need to keep high on our radar and address going forward. Sherief, thank you so much. And thank you everyone for joining today.
Thanks.